started working at the Australian Cancer Survivorship Centre about 9 months ago, so I've been on a very large learning curve, and as I often find in the things that I do in general practice nursing, I've become extremely passionate about this work. So I was brought on board as a project manager for a particular project which I'm going to talk about today. But the reason I was brought on to the Cancer Survivorship Centre is because of my background in general practice nursing. And basically the problem is that the hospitals and general practice don't work well together, and I would suggest that's across the board. And then there was some sort of sense that if I came along I might be able to fix all those problems. Basically what I've been able to do is identify a whole raft of problems which I actually can't fix. But you know, hey, I'm going to give it a good hard crack. So what I'm going to talk to you today is about cancer survivorship as a distinct phase of cancer care. It's all new language for me, so I'm going to talk to you about what I've learnt along the way, and the chronicity of late effects. So these are people who actually have had a diagnosis of cancer, have had their treatment, they are cured, but they have ongoing life-impacting chronic illness because of the treatment of cancer. And there is a very extensive list of ongoing problems that really do require the management of clinicians in general practice. I'm also going to talk about then how we can utilise the already existing care paradigms that we have in chronic disease management. I've never been told I don't talk loud enough. How we can use chronic disease management to support our patients through these phases. And then I'm going to report on the general practice clinical placement pilot program, which we've just completed the actual clinical placement and I'm doing the evaluation on, and already the results are mind-blowing. So the good news is that we have an increasing rate of cancer survivors, and that's because we've got improvements in screening, we've got improvements in treatment, the whole range of new targeted treatments, and of course we're getting older. And the dilemma is the majority of this post-treatment care for patients who are in a post-treatment phase is still being mainly managed in the hospital sector. And that means that patients are not getting their full needs met, and patients are having expensive care, often in an institution that scares the bejesus out of them because it reminds them of the time when they had their treatment for cancer. And also it's often hundreds of miles away from the context of their community. So the solution needs to be in general practice. So how can we get these two sectors working together? So survivorship is not a term that I was very familiar with when I first came to work at the Survivorship Centre. And when you look at the definitions across the international world, they vary. In the Australian context, we talk about survivorship commencing at the end of active treatment. So somehow you end up in a hospital like Peter Mac. You might have come there through a referral through a general practice or a community health centre, or you may have just actually presented to the hospital yourself, and you've had your treatment and you've finished that active treatment phase. You are then deemed to be in survivorship, and that is till the end of life, and the end of life may have nothing to do with your cancer at all. But internationally, for instance, the National Coalition of Cancer Survivorship talks about cancer survivorship being at the moment of diagnosis. Survivorship care really came to the fore around about 2005 when the Institute of Medicine produced this report, From Cancer Patient to Cancer Survivor Lost in Transition. And it highlighted what are the requirements of a good, high-quality survivorship care model. And they've identified that it must include prevention of new cancers, because we know that people who've had one cancer are at a risk of getting a secondary, and also surveillance for cancer spread once that cancer has been contained, making sure that it doesn't come back, looking at ongoing assessments and interventions for the psychosocial and medical effects of the treatment, and also looking at coordination between primary care and specialists. When I first started working in this area, I got really confused because we were talking about specialist care. Well, as a generalist, I provide specialist care. In general practice, the craft that we deliver to our patients is generalism, and that is a specialty. So to try and break this all down, and while I was preparing the project plan and the ethics application, I came down to using two terminologies. Specialist relates to hospital-based specialists, and generalists relate to what we are. We're specialists in generalism, and as generalists, that includes general practice nurses as well as GPs. So for many patients who have a cancer diagnosis and cancer treatment, they have their treatment and then they return to their normal life and they are well and they have no impact from their actual treatment. They often have a strong, re-energised attitude to life, and they want to take on some lifestyle modifications to make sure they stay that way. But unfortunately for others, that doesn't always happen. And one of the, through the time that I've spent visiting outpatient clinics and sitting in on the multidisciplinary team meetings, these, the impacts of cancer are enormous. So someone who's 2 or 3 when they were diagnosed for leukaemia, and they're now 45 or 50, have huge ongoing problems related to the treatment they had when they were very young. That's because they were very young, small, forming bodies and brains that had an enormous assault from radiotherapy and chemotherapy. And I look to our colleagues in the UK, mainly because my mate Sue's here, and as often we find, the NHS is a little bit forward-thinking than where we are. And many cancer survivors don't like the terminology survivorship. It doesn't resonate with them. And in the UK, they talk about recovery, which personally I like. And they've developed a recovery package. And this recovery package means that across the key points of care that a cancer survivor or recoverer is journeying through, they have holistic needs assessments. So at different key clinical points of their care, their needs are assessed. What do we do in general practice? What are the validated holistic needs assessment tools that we use in general practice for patients who've had a cancer diagnosis or are on a cancer journey? I'm not sure we've got them. So that's another piece of work. Also in the UK, as part of their recovery package, the patients are given a treatment summary at the end of any point of active treatment, and that treatment summary is sent to the patient, but it's also sent to the referring GP. In Australia, we have a thing called a survivorship care plan. I'd never heard of it. And the survivorship care plan is a plan that a patient is given at the end of active treatment, and also a copy is sent to their referring GP. The problem is that the referring GP may not be the general practice or the general practitioner who is continuing with their care afterwards. And one of the key drivers is that the general practice is incentivised in the UK that 6 months from discharge, the patient will have a cancer care review. So it's part of the QOF, the Quality Outcomes Framework. So it's a little bit like, our health assessments, but it's specifically around cancer care. So we don't have any of that infrastructure at the moment. Also, our UK colleagues have got a competency framework for nurses working with adults in cancer care. Again, this is not a tool that we have. Interestingly, there are 8 domains that are mentioned in this competency framework, and these are the domains listed. And I was incredibly impressed that they had professional practice and leadership and interagency and partnership working. So it's about how you work outside of the walls of your practice. And I think, again, that's probably another area that we need to consider as nurses working in general practice, how we actually work across boundaries. So this is a list of just some of what we call late effects. So we know that chemotherapy is toxic, and we know that radiotherapy ages cells. So if you're even getting a very targeted treatment, you can't but damage the good cells as well as the self-replicating harmful cells. And these late effects can manifest years or even decades after treatment. So it made me think, what do we do in general practice to identify patients who may have been diagnosed of cancer 10 or 15 years to monitor our patients for these conditions? So a woman who had breast cancer and has had her left breast radiated has got increased risk of cardiovascular abnormalities because you've also irradiated the heart that sits behind that breast. People who've had bowel cancer, bladder cancer or pelvic cancer and have had radiotherapy will have a lot of issues around urinary, bowel and sexual function. So it made me think, well, I don't know whether we really know in our practice population who's had cancer and who hasn't. When patients come to our practice and they fill out their form and their family history is written down or their past medical history is written down, some patients may not actually want to nominate that 10 or 15 years ago they had cancer because they feel cured. But still, if they had, for instance, a head and neck cancer and they had radiation to that area, they're at high risk of having thyroid cancer. But we're not looking for it because we don't know about it. So I've had a bit of a learning curve on clinical knowledge, and it's made me realise that it's an area of practice that in general practice we don't actually do a lot of work in. Data-wise, it's very difficult because when we enter a cancer diagnosis, it's not entered in a way that it's retrievable. Tools like the PenCat tool can't actually do any searches on parameters that would identify patients who've got a past history of cancer. So I think we've got a lot of work to do. If we look at the research, there's been some systematic reviews that compared care that's been given predominantly in primary care or care that is given in hospital-based settings for these patients. And some of the findings have shown that patients who've had a cancer diagnosis and continue to have their post-treatment cancer managed by the hospital do really poorly for all the other parameters of health. So if you've had cervical cancer and you continue to go back and have your care provided by that cancer hospital, your cervical cancer may be very well managed, but you don't get encouraged to have mammograms or to have your cholesterol checked. So we're then talking about a disease or organ-specific care rather than the holistic lifelong care that we provide in general practice. Boy, I better be quick. And also, so I'm going to move on. So what sort of numbers are we talking about? In Victoria, 230,000 survivors of cancer. So these are people who have had or are currently going through a cancer diagnosis. It's about 1 million in Australia. There's in excess of 2 million survivors in the UK and in excess of 14 million in the USA. So we're not talking small numbers. Great that they're surviving though. So there's also been quite a lot of research around what does shared care look like. So if we're going to share care of patients between hospital-based care and general practice, the clinicians in the hospital, and it's become quite evident in the research that I've been doing, they're actually not sure what we do and they're not really confident that we can do a very good job if they knew what we were doing anyway. But the research has shown that when there is care that is post-cancer treatment care that is either primary care-led or shared, the patients do really well. It's best for the health system because it's cost-effective. It also takes some of the overcrowding and work burden off the hospitals. The patients do just as well through their psychosocial and medical life outcomes, and also it costs better. But the patients like it better. So when we talk about shared care, what we mean by that is that it's follow-up care where there's usually a partnership between the hospital and the usual general practice. And for that to occur, we need to have some agreement on clinical guidelines. We need to have agreement on what we need to look for and what we need to screen patients for. And also, once we've actually identified that there is a problem, how do we fast-track that patient back into that tertiary institution for acute care? When I speak to the clinicians at Peter Mac Hospital and they say we're really worried about relinquishing our patients to general practice because, you know, we're not sure they're going to be cared for really well. We're worried that in fact they won't have the investigations that they require. We lose them to treatment. And my response is, well, that's exactly what happens when we refer them to you. when we refer our patients to you, we lose patients to treatment. We get completely shut out at the front door of your hospital, and then at the end, at some point, the patient comes out and is returned to us, and we have no information about their care. So similar concerns. So I was brought on to Peter Mac to establish a general practice clinical placement pilot program. And this was to start the conversation to try and get these two clinical groups together and to see whether we could have some knowledge transfer, that general practice teams could learn more about the hospital and vice versa. And the idea was that this would be the early conversation as to how we could set up shared care, even though there are some demonstration models in other hospitals. I was asked to recruit 4 to 6 GPs and 8 to 10 general practice nurses. When we got to 16 GPs and 12 practice nurses, I had to shut recruitment. It was overwhelming, the number of people who wanted to be involved in this program. And it was a huge commitment. It's 10 hours of clinical placement, so 2 to 3 visits to the hospital. And there were 5 participating cancer streams: lower GI, breast, uro-oncology, the late effects clinic and skin and melanoma. So people chose 3 of those streams and came and attended a multidisciplinary meeting and then sat in on the outpatient appointments with the surgeons, the medical oncologists and the radio-oncologists, and with the nurse coordinators. We received ethics approval through Peter McCallum, and we established the research question of, is a clinical placement feasible and professionally clinically valuable? And I am trying to speak very quickly. Was that 2 minutes or were you being written? Right, okay. The preliminary findings, and they are preliminary, but they are very strong. Yes, the generalists, so the nurses and the GPs, identified the clinical placement as an absolutely overwhelmingly brilliant experience, and they wished that they could have stayed longer. They thought it was a great opportunity to view the journey that their patients were going through. They wanted to understand a little bit more about how the hospital worked. They were able to build relationships with the clinicians in the hospital, and they also gained a whole pile of new knowledge around the current treatments. I thought this quote from one of the general practice nurses summed it up. It was opened my eyes to the practicalities of care which could easily be attended to in our local general practice. Our generalists also said, this is our work. Cancer survivorship is what we do. We've already got models around chronic disease management to be able to incorporate it, but we need some advice and some support from the hospital. That doesn't exist at the moment. There are huge cross-sector workflow constraints. The hospital that I can only really speak about Peter Mac, we are not very technology enabled where general practice is. It's very much a paper-driven communication system, and that really doesn't work well for most general practices these days. It was also very clear from the hospital clinicians that they had no idea what general practice does, and that when they talk about multidisciplinary care, they're only talking about the teams within the hospital. They don't know how to communicate outside of the hospital. They don't know how to get blood test results into the hospital. So a lot of care is being driven by the hospital for convenience, and for a patient to travel 400 kilometres to get their PSA results, you would have to wonder why. Another couple of quotes. They also found it's been a long time since we've been in university, so learning about the new age targeted treatments meant that they felt more empowered to be able to look after patients when they were returned to community for that post-treatment care. So look, I think it's going to be, I think when we eventually get through the evaluation, I think this is going to be an incredibly important piece of work, of course, I'd say that. I think these quotes are amazing. I think they give great insight. Very clear that we need to actually get these clinicians from these two different sectors actually learning together and working together. There are a lot of myths out there. There are a lot of cultural challenges where we need to improve the profile of general practice within the tertiary setting. And what was also very clear is that when the specialist in the hospital sees the patients and then they write a letter, they actually don't think of it as clinical handover. In many ways, I'm just telling you what I've done. It can take up to 3 weeks from when that letter is dictated to when it lands on the GP's desk. And then what happens? Because it's paper-based, it gets scanned, and we very rarely go and look in the scanning documents, do we? So there's all this information that is being lost, so we can't do continuity of care, and I actually question whether we can do safe quality care either. Patients are falling through the cracks. So the conclusion is that there's strong interest and commitment. There is a need to get to break down some of these barriers, to challenge a lot of the cultural beliefs, and also to look at how we can communicate better together. The placement has given me confidence that there are common treatment pathways that if we were made aware of them early on, and this gets back to education, which is another key outcome, we'd be in a better position to support our patients, and at the moment we're not really aware. Again, I think a very telling quote. There are lots of resources, I couldn't list them all, but these are just a few. But I'm more than happy if anyone wants to know more. Please send me an email. This research will be published. Hopefully there'll be an article in Primary Times as soon as it's available. And it's a bit like Watch This Space. We're hoping that this project was funded through the Department of Human Services in Victoria, and we're hoping that they'll fund a secondary go at it. Thank you.